planned from our medical oncology colleagues. So we have Professor David Goldstein, Dr. Helen Key, Dr. Melisha Zayed, Dr. David Thomas, Associate Professor Kathy Tucker, and Associate Professor Natalie Taylor. So we've got a big group of presenters today. We're going to do questions after both of the cases. So put them on the chat as you go, and then also questions at the end. There's a microphone for questions in the room. Otherwise, I'll hand over to Professor Goldstein to get started. Thank you.
So thank you. Thanks for the opportunity to present today. And as Neil Diamond would say, hello to 3 people out there, namely everybody online, as well as all of you in person here today. So the reason we're giving this talk is because a new initiative has begun at Prince of Wales, and that initiative has come out of work that was spearheaded by Professor David Thomas, who'll talk to us later on. And it's about, and Natalie Taylor will talk to us about later on, it's about trying to find ways to integrate into the health system the revolution of genomics and what we call precision care. And precision oncology is at the forefront for a number of reasons. But just to tell you who's speaking today, so Dr. Helen Key is the molecular fellow in our new precision clinic, and she'll be presenting some relevant somatic cases. Dr. Melisha Zayed is a cancer geneticist and a medical oncologist, so very well suited to her presentation. And then an overview of molecular oncology and the larger program that's headed by Professor David Thomas, who's now the director of the Centre for Molecular Oncology in the School of Biomedical Sciences at UNSW. Kathy Tucker won't be joining us today, but Melisha Zayed, also a clinical cancer geneticist, will give some overview as part of her presentation. And then we'll really hear about this really new idea of implementation science, well, new to some of us, sorry, but implementation science and how the challenge of integrating a new idea into routine practice is assisted by this whole development of an implementation science approach. So let me just set the scene a little bit. So precision oncology. So precision medicine is a global term. It's not an oncology term. It's a form of medicine that uses information about a person's genes, proteins, and environment to prevent, diagnose, and treat disease. So we hope that ultimately the vision is that what's learned from precision oncology will actually influence many other health conditions. But specifically about precision oncology is about the ability you can see to, where's a pointer? Is that moving? Yeah. So you can see here's a lung tumor. A specimen is taken from it, the usual H&E type immunohistochemistry to say what type of cancer it is. But much more important is the ability to take advantage of first the Human Genome Project and then the tumor somatic genetic projects that have started to understand the basis, the genetic basis of the progression of initiation, progression, and metastasis, and learning from that what particular genes would be actionable. So what does that mean? That means that there may be a drug that will interfere in its aberrant function and reverse it, and by doing so, change the nature of cancer and its progression. And some other more complicated issues like variants that Melisha will talk about. So what's this clinic idea? Well, the clinic is set up with a specialist clinical team in what is not quite unique, but almost unique, is combining both cancer genetics as well as medical oncology and bioinformatics in a single joint review of complicated cases where the need to understand which molecular profiles matter and which don't, and you'll see good examples of this. But in establishing this novel model of care, there's an implementation platform that is, how's it done? How's it integrated? What are the barriers and what are the facilitators of doing a clinic like this? And setting up the idea of a iterative learning health system. So from every case, it becomes clear how one should adapt and change, and ultimately maybe become redundant. And that might be the ultimate success, is that the clinic will close. But anyway, that's a long way away. So what are the goals? First goal is to mainstream the service, like a lung MDT, like a brain MDT, nothing special, right? But not anatomically based, but molecularly based. Particularly internal referrals that are complicated, but also for the multi-tumour regional and rural oncologists, getting access to that specialised expertise quickly so they can then deliver assistance to their patients. And so the idea is particularly important is to maintain mobility and trust between referrers and expert panels. It's not about taking over care. It's not about looking for more patients to be treated inside this. So it includes therapeutic advice from a multidisciplinary approach, liaising with international as well as local experts if needed, identifying the hierarchy of potentially suitable trials that take into account not only the molecular profile, but more importantly, the clinical circumstances and the geography of the individual patient. It will occasionally result in patient consultations in person or telehealth with either medical oncology or cancer genetics or both, as you'll see examples of. But often it will be more about a discussion and review of that patient's circumstances. So without further ado, we should move on to the actual cases. I think Melita is first.
Thanks, David. I guess the cancer genetics department is a department staffed by medical specialists as well as genetic counselors. And our role is in looking after families who are born with an increased predisposition to developing cancers. So with that in mind, I will present case one. So this was a 56-year-old male who was referred from regional Victoria. He was diagnosed with a metastatic bowel cancer with isolated liver metastases. The pathology assessment also told us that he had a mismatch repair protein proficient tumor on immunohistochemistry, which I guess if there's loss of mismatch repair protein on immunohistochemistry, that indicates to us that that Lynch syndrome may be possible, which is an inherited condition associated with increased risk of developing bowel cancer and endometrial cancer. So this was telling us that this is not something that we needed to investigate. KRAS was also wild type. Now, the mismatch repair protein and KRAS also has implications for treatment, and the KRAS also prognostic implications, which are relevant in the decision-making for medical oncologists. So as a result of the pathology, the decision was to aim for a potentially curative treatment. So they were planning to resect the primary lesion as well as the 3 liver metastases, following a course of neoadjuvant chemotherapy first. So he went on to have his primary tumor resected, but unfortunately, while he was recovering from the surgery, it was discovered that his liver metastases had since progressed, and now he had bilobar liver metastases, which meant that curative treatment was less well, it wasn't something that was being aimed for anymore, and he was having palliative treatment with the focus on disease control and quality of life. So then the chemotherapy was changed as a result to FOLFOX and bevacizumab. It was at this point with this new, I guess, focus on care, he was referred to the cancer screening program, the CASP study, which is a tumor profiling program. And the question was, I guess, they were looking for therapeutic options. So, and because we are genetics, so I'll go on to the family history a little bit as well. The squares are males and circles are females, and any symbols with the strike through are representing deceased relatives. And the coloured in sections are representing different cancers. So he himself had a history of multiple skin cancers at a reasonably younger age. His mother died from, he reported to be a potentially gastrointestinal tract cancer at 43. So he was 4 years of age at the time. They were living overseas, and after his mum passed away, his father moved to Australia. And his father died at an older age with an esophageal cancer, and his paternal aunt had a history of breast cancer, and his maternal aunt died of some kind of cancer in her 50s, but again, because the mom passed away, he didn't really have a lot of information of the cancer type. So I guess this family history, there's a younger onset cancer in the mother, but otherwise nothing really is meeting obvious clinical criteria for testing, for genetic testing or germline assessment. So this was the tumor profiling through the CASP program. Sorry, maybe I just need to step back a bit because it's you can see that these are the genes that were found on the right, the APC, BRCA1, and other genes. Now, this is profiling the tumor itself, so it's doing genetic testing on the tumor tissue. Sometimes, though, if someone is born with an inherited genetic mutation, that can also show up on tumor profiling. Not always, but most of the time, depending on the genes tested. So in this report, the genes that have been marked with the narrow are relevant, are associated with an inherited cancer predisposition condition. And so I guess the question for in this setting is often, well, how do we know when we're just profiling the tumor, what is potentially inherited and what is something that is really just something that's been acquired on transition from normal tissue to tumor tissue. And there are some some indications. It relates to the genes as well as the variant allele frequency, which is the VAF, and the tumor purity. I won't go into that, but all of those things give us a sense of likelihood of a gene fault being germline or not. And using those methodologies, the CAS program identified that the BRCA1 mutation or a pathogenic variant was predicted to be potentially germline. And this was the recommendation that went with that report, suggesting that the patient should be assessed in a genetic service. So the patient was referred to our clinic for this germline validation. In the Precision Care Clinic, he was seen by the genetic counsellor, so Bridget, whose photo's there. Unfortunately, she's on school holidays, and by myself. And the germline testing, the validation testing was requested. Which was confirmed. The likelihood of it being germline was predicted to be about 80%. So our conversations with him talked about interpreted the molecular profiling result for him and the implication of the BRCA1 finding and what that would mean for his family if it was confirmed to be germline. When the results came back and we went to the results appointment, he let us know that the chemotherapy, he did have good response to chemotherapy, but he developed some neuropathy due to the oxaliplatin, which was ceased. And this is relevant because we often think about BRCA1 being sensitive to, or BRCA1 and 2 being sensitive to platinum-based drugs, which is oxaliplatin. So in terms of the family implications, we then had a further discussion about cascade testing, so testing other individuals in the family. BRCA1 gene fault or pathogenic variant is associated with a high risk of developing breast cancer and ovarian cancer. And then when we sort of teased out the family history, it was thought that maybe the mother's cancer history, it may have been a primary peritoneal cancer, which would be in keeping with the BRCA1 gene fault rather than a bowel cancer. So for him, as somebody who lost his mother at a very young age and he was himself looking at dying himself from a cancer, the implication of this finding for his daughter was very relevant to him. He was very grateful and very keen for her to engage in preventative opportunities. So, of course, the question from the clinician also was, the therapeutic implications of this finding. And when clinicians in their local clinics are faced with these profiling reports, that's, I guess, one of these things that they're thinking, the BRCA1, is there something that is just we've just found by chance and it's unrelated to the cancer, and therefore we shouldn't be thinking anything, the treatment shouldn't be influenced by this, or is there something that should inform care? So Helen kindly has done a literature review, sort of putting together all the data, literature that's out there, and we are feeding that back to the local oncologists to aid in their decision making when they're now needing to think about the next treatment option. And as an aside, Natalie's team, who've been collecting sort of the feedback from the patients for, I guess, as part of the implementation side of things, the feedback from the patient was very positive. They thought it was the best first meeting of the last 12 months of appointments. And a lot of that surrounded around not feeling rushed, which is credit to Bridget. And also, I guess they felt that information was coming in a lot of little bits and pieces, and they appreciated the opportunity for things to be put together and put into sort of context. And they felt that there was a real focus in this clinic on patient understanding and pitching things to the right level, which again is credit to Bridget. So, and they really valued the opportunity for germline testing, describing it as a tremendous thing to have found. So I know Kathy couldn't be here and she wanted to talk a bit more about the clinic itself and her perspective on the clinic. So I thought I might just take liberty of just putting my thoughts in terms of why we thought that this combined clinic is a fantastic opportunity. Cancer genetics and I guess medical oncology, there's just so much overlap at the moment, and more is likely as we move forward, that this clinic and the MDT setting is really quite synergistic, and we are really learning from each other. And it's so far and it's only sort of recently launched, but it's been such a dynamic experience, and we are adapting to clinician and patient needs as they come up. There are gaps that we hadn't realized were there when we designed the study, and more we are finding opportunities where we can assist. So from a genetics point of view, in terms of working with the medical oncologist, the tumor profiling and the incidental findings, it sort of works really well because they are looking at the treatment side of things and we are looking at the germline side of things, and we can do the back and fro from with each other. As well as, I guess, another area of interest is looking at the use of oncological drugs in the genetic space. So looking at people who don't have a cancer diagnosis, but potentially exploring opportunities for prevention in these high-risk individuals, as well as treatment of potentially benign tumors, which are not cancers, but could benefit from a oncological drug. So von Hippel-Lindau is, I guess, a space that David Goldstein and Min Lee, who's one of the cancer genetics geneticists at our service, have been working together on, and it predates the clinic. But this is a space where individuals with a predisposition to developing lots of debilitating tumors and lesions can really benefit from an oncological drug. And I guess the plug here is that there is a PBAC petition that's underway currently for access to a drug called belzutifan, which David and Min has been using on these patients. And it's closing today. So if any of you have ever looked after or know anything about von Hippel-Lindau and the burden of disease, we would greatly appreciate your signature. So Kathy and Min has been working very hard behind the scenes to get this happening or get this going for the patients. And again, this is something that the clinic is well set up for. The other area where medical oncology and the cancer genetics can really collaborate is in screening strategies, where I guess the screening strategies are not as well developed because I guess cancer surveillance is something that is something that the medical oncologists are very comfortable with, and we can lean on them to guide some of these practices as well. So it's a really interesting, exciting thing to be happening, and we're very delighted to be part of it.
So any quick questions about this? Any questions? Think about things later. So now we're going to talk about the medical side of this.
Hello, my name's Helen. I'm one of the, I'm the fellow in the molecular precision group. So we've got two cases to present from the medical oncology perspective. This is hopefully an interesting case to illustrate how precision oncology is being integrated into clinical practice and the type of impact that it can have. So this is a case of a 35-year-old woman who presented to a regional New South Wales hospital with abdominal pain and obstructive jaundice with a bilirubin of 156 and raised tumour markers as well. As part of the initial workup, she had a PET CT which showed a mass in the head of the pancreas, which extended less than 90 degrees around the superior mesenteric artery. In other words, it looked resectable. There was also an FDG avid transverse colon lesion, as well as two hepatic lesions, one being over 6 centimetres in size. At the MDT, a consensus was made to undertake a Whipple's procedure and a right hemicolectomy, given the benefit of the doubt that the liver lesions may be oligometastatic disease from the colon, which is, of course, a curable situation. Unfortunately, the pathology showed that there was a stage 2 node-negative colorectal cancer and at least a locally advanced acina pancreatic carcinoma with adverse features that made it much more likely that the liver lesions were in fact pancreatic cancer, which was subsequently confirmed on liver biopsy. So being a fit young patient with a young child, the big gun chemo regimens were brought out for this patient, and she had the first standard of care palliative chemotherapy regimen with 3 drugs called FOLFIRINOX, which is a combination of 5-fluorouracil, oxaliplatin, and irinotecan. which unfortunately have very little impact with disease progress within 2 months, in addition to hospitalizations due to treatment toxicity. The next line given was a doublet combination of gemcitabine with Abraxane, which provided around 4 months of stable disease and then again, unfortunately, disease progression. So what now? Unfortunately, standard options that are available in the third line for metastatic pancreatic cancer are not very promising. So we turn to a precision approach. What is now standard practice, particularly for a young patient with two synchronous cancers, was germline genetic testing, even though she did not have significant family history. For this patient, there were no pathogenic mutations identified in BRCA1, 2, POWH2, and other clinically important mutations, both for her and her family. This patient was then enrolled onto a research study that provided molecular analysis of the tumour itself and had a striking feature, which was a very high tumour mutation burden. And as recommended by the Tumour Molecular Board here, the most highly recommended approach that they recommended was a combination immunotherapy trial using 2 checkpoint inhibitors called durvalumab and tremelimumab, which is available on an immunotherapy trial. So TMB, or tumour mutational burden, represents a number of mutations per megabase harboured by tumour cells. The general thought is that with a higher TMB, there's more immunogenicity within the tumour and therefore potentially better response to immune checkpoint inhibition. But as a general biomarker, TMB has proved to be a fickle one. It seems to be a helpful biomarker in some cancer types, but not in others. TMB is also associated with, but not always, with microsatellite instability or deficient mismatch repair genes. In pancreatic cancer, a high TMB is a rare feature. In some case series, it seems to be around 1% of pancreatic cancers that have this, and 40% of them are microsatellite stable, which is for this patient. And of course, TMB and microsatellite stability are not part of standard molecular characterizations of pancreatic cancer. 204 is actually a stunningly high TMB. To put that into perspective, the FDA has approved pembrolizumab in any tumour type that has a high TMB, and a high TMB according to that classification is greater than 10. For pancreatic cancer, TMB, deficient microsatellite, or deficient MMR or mismatch repair proteins, or microsatellite instability seems to be an emerging biomarker for immunotherapy. There was a phase 2 trial called the Keynote 158 that included 22 patients with deficient MMR or mismatch or microsatellite unstable pancreatic cancer, and they saw 4 responses, which was about a fifth of the cohort, including 1 complete response. I also did a literature review, and there seems to be 8 case studies of high TMB pancreatic cancers receiving PD-1 inhibition or immunotherapy, and with 2 complete responses, 5 partial responses, and 1 durable stable response. But of course, there's a significant reporting bias in case reports. So for this patient, she was referred for a third-line clinical trial based on these tumour molecular results. And this was a CT at study baseline. And 6 months later, there was a very good response. So good, in fact, that hemihepatectomy was performed for the hepatic oligometastases because it was clear that the disease within the liver had responded very well, and there was also no evidence of disease outside of the liver. So this was performed at 1 year and 4 months from diagnosis. This patient then completed the course of dual immunotherapy as per the study protocol at 2 years from diagnosis. And earlier this year, at 5 years and 3 months from diagnosis, there was still no evidence of disease recurrence. So this is a fantastic outcome for someone with metastatic pancreatic cancer. And of course, something that we would not have thought of and would not have provided if we had not known about that particular TMB. So moving on to our next case study. This is another young female in 30s, a 38-year-old female who was diagnosed with stage 4 colorectal cancer. The standard molecular sort of features that we look at in colorectal cancer or advanced colorectal cancer is looking at RAS and RAF. And for this patient, they were wild type, meaning that there were no mutations. She was also proficient in her mismatch repair proteins as well. This patient's history was significant for pediatric neuroblastoma when she was aged 6 months with complete response to vincristine. There was also a history of melanoma in the family and a sister, and there was a paternal uncle and cousin who were both diagnosed with colorectal cancer, and one had been diagnosed with testicular cancer as well. Given this history, but also given her age, germline testing was undertaken with a large panel for many different genes, and no pathogenic mutations were identified again. As is standard practice, this patient received a doublet chemotherapy with an antibody therapy. So in the first line for this patient, she received a combination of FOLFOX, which is 5-fluorouracil with oxaliplatin, together with bevacizumab, which provided her with a partial response for about 7 months and then disease progression. In the second line, she received FOLFIRI, which is 5-fluorouracil again as the backbone, with irinotecan, with cetuximab, which is an EGFR inhibitor, which again gave her a partial response for another 7 months and then progression of disease. So what now? So in a very similar vein to the first patient that I spoke about, in the third line setting for metastatic colorectal cancer, standard options for chemotherapy are not usually very impressive at all. So again, turning to a more precision approach, a tumour testing was undertaken for this patient on the same research study that the other patient was on. And a number of potentially targetable mutations were identified. But particularly, and these are not ranked clearly, there was an ERBB2 or HER2 amplification of 30 copies. What is useful, of course, is to have a molecular tumour board to actually interpret those findings and come up with recommendations. The therapy recommendations at the top here were about the RAS wild type. That's also already been done, and that's based on the fact that we knew that she was RAS wild type. So that was the second line therapy already given. So in terms of other trial options available for this patient, the molecular tumour board recommended an ERBB2, targeting the ERBB2, with a trial using the combination of trastuzumab with tucatinib, and also mentions other investigational agents like anti-HER2 antibody drug conjugates. So HER2 in colorectal cancer or HER2 amplification rather, is an uncommon finding. It's found in about 3 to 5% of patients with colorectal cancer, and this is not a part of a standard colorectal panel. However, looking at, again, the literature, it looks as though that the overexpression or the amplification of HER2 is a negative predictive factor. People do worse. And the reason is they think that it interferes with EGFR inhibition. HER2 itself is an emerging treatment target in colorectal cancer. These are all the names of smaller phase 2 trials that have been undertaken using different combinations or single agents of HER2 targeting drugs. Mountaineer, the one at the top, is the most complete, looking at the combination of trastuzumab and tucatinib, which is interesting what was recommended for this patient, which showed an overall response rate of 38%. And a median progression-free survival of 8 months and overall survival of 2 years. The antibody drug conjugate that the molecular tumour board speaks about, so that's likely to be something like this. The Destiny colorectal or CRC2 trial, which used trastuzumab deruxtecan and had a lovely overall response rate of 45%. However, looking at the data, it's best in patients with immunohistochemistry, strong expression, which they weren't able to actually look at for this patient because of the lack of tissue. So outcomes. So this patient was referred to this trial based on the tumour molecular findings, which we would not have known about otherwise, unless we had done that somatic or tumour testing. For this patient, there were two very good outcomes. So the response lasted for well over 12 months, or over 12 months for this patient, which is a great outcome in itself. But it was also very well tolerated. She didn't go to hospital at all. In all the notes, it looks as though she really did well with the treatment. It didn't interfere with her quality of life. And another way of looking at this is to look at a CEA, or the tumour marker. You can see quite a dramatic drop that stayed very low for quite a long time.
So any quick questions before I found that's the case? If not, thank you very much. So now we're really going to take a broader step back and a look at the field in general. And in the first part with David Thomas, and then we're going to look at how this experiment, or this clinical experiment about clinical introduction of a service that I hope we've demonstrated to you, can make a major difference, and not necessarily one you would know about with a conventional approach. So David Thomas, Director of the Centre for Molecular Oncology, will first speak to us.
Don't have any slides. So my task here, I guess, is to give you a sense of perspective about where oncology is today. And this is a very broad summary, because I assume that many people in this audience have a very broad, diverse health background. So cancer kills currently about 48,000 Australians. In about 2017, in higher income countries, an analysis of the causes of mortality across the community suggested that for the first time in 40 years, cancer had outstripped cardiovascular disease as the leading cause of death in higher income countries. So it's a big ticket item. And the way that we think and have managed cancer over the past century has been based around two major principles. The first is anatomy, the idea that a tumor arises as a lump within an organ system and you need to chop it out. And that's still very important to the curative treatment of most solid organ cancers today. In about 1850 or so, they looked under the microscope at the structure of tumors and discovered they were made up of cells, which is an incredibly important advance. And then the German biochemists and others developed stains that actually selectively stain bits and pieces of those cells. So you ended up with pink cells or blue cells, depending upon whether hematoxylin or eosin was being used as a stain. And we still use that today in the same way. We looked on the microscope, and all the diagnostic reports in cancer are based around what's called the morphology of those tumors. And an incredible amount of science, or rather epidemiologic, I would describe it as science, but the nosology, the classification of those tumors according to that appearance has underpinned a lot of the advances since we began to treat cancers in a more scientific way. But it's still empirical. So since about 1945, 1950, when the first cytotoxics were developed in Boston and were first applied to kids with leukemias, actually, we started to use drugs which selectively killed rapidly dividing cells. We didn't know why, and we don't know why some of those drugs work or not. But over the next 50 years, we've gone from a 25% 5-year survival for cancer up to about what it is today in New South Wales, which is 70%. Now, that approach has been, it is what we might call an empirical approach. We don't know why large round blue cell tumors or small round blue cell tumors or adenocarcinomas or squamous cell carcinomas respond in the ways that they do, but we know they do simply because we do trials of enough patients and we can see the effect size and we have good controls. And you need to have controls if you're not taking a biologically informed view of how you intervene. So what's happened in the past, really since the early 1990s, there was a drug developed to target the chronic myeloid leukemia mutation, the BCR-ABL fusion, which was actually identified in 1963 by Peter Lowell and David Hungerford as a sort of chromosomal translocation. That was the first mutation ever identified. And that drug, Gleevec, was the first rationally designed drug against a cancer target. It's been spectacularly successful as an individual example. Today, Gleevec in chronic myeloid leukemia, I remember when I was a registrar treating CML patients in the bone marrow transplant service, we knew that after 10, 15 years, they would inevitably progress into blast accelerated phase and blast crisis, and then they would mostly die unless you managed to transplant them. But now today, Gleevec, an oral tablet, has converted some patients into what looks like long-term molecular remission. That's an example from the very beginning of this whole modern era, but the general principles have applied generally and inexorably. So today, when in our own program, about 1 in 3 patients, actually 37.5% of the patients that come into our MOST and CAS screening programs with no other treatable conventional treatment options will have a drug target which will double their survival if we can get access to the drug. It's not a standard of care. This is all being done through research, and we're trying to find ways of mainstreaming it. And that includes how the health system considers how it affords the successes of science in terms of impacting on health outcomes. But it's really critical for you to appreciate that we're not in an era anymore which is the same as it has been when we, so to speak, grew up, at least when I grew up. So today we have a biological prior to the way that we think about the disease, which has no statute of limitations for the care of cancer patients. This is not an esoteric academic's preoccupation. These are things that if it happened to you, you would want to get access to this because you know it would make a difference. How we implement that in the health system is in fact what this whole clinic is about, because just as we have to think about there being no statute of limitations to taking a molecular view of a disease and then using that information to impact upon health outcomes, so we have to think about how that gets mainstreamed into the healthcare system. And I think this is a very exciting development because the creation of a clinic where, you know, colleagues like Melita, who would be attending the 27% of cancer patient clinics, that is, say, breast, bowel, and ovary, where the majority of familial cancer cases are referred. That's what only 1 in 4 cancer patients is thought to have a genetic basis in our current system. Would not normally have anything to do with David Goldstein, who would be in a separate clinic beavering away trying to prevent people from dying with systemic therapies. We have to think about how we create a clinic where those two people are right next door to each other, because we're talking about the one patient. We're not talking about one person who gives drugs and one person who gives advice about how to minimize the risk of recurrence and or stop the second cancer killing the patient. You're talking about a patient-focused approach. And that's the irony about all of this. It's very clinically focused. This is not about genomics or rational drug development or artificial intelligence or drug design by computers. It's about trying to think about all of that and still have the patient right at the heart of it, including knowing when it's time to pull out, which I think remains a real challenge for those of us utopian idealists who think that if we're just given enough resource, enough time, we can fix almost any problem. So there you go, no slides.
So finally, to talk about how to translate those lofty Olympian ideas into practical day-to-day activity, that's with Nath.
Hi, everybody. Thanks for having me today. I'm not a clinician, so if I muddle up any terms, please forgive me. And there might be a few muddles on my slides just from the animations. So the first thing that I wanted to talk to you about today was really the research to practice gap. So I had a little research on the internet before I pulled this presentation together, and I found from the World Health Organization that 20% of registered clinical trials focused on cancer. So it really is leading the way in terms of advancing the science. And the problem with that is that we have to really find ways to speed up the way in which this gets into practice. So I think really that means that these advances are really changing the way that we need to think about managing cancer in healthcare. And we know that clinics will look very different in 10 or 20 years from now, but we really need to start thinking about how this will happen and how the health system will keep up. And that's where implementation science comes in. We can support and speed up the health system change. And there are two key ways that we can do this. One is through implementation practice and one is through implementation research. So implementation practice is really a suite of methods and tools that we can use to try and speed up the rate of translation of evidence into practice. This can include things like understanding stakeholders' needs, current processes that occur within a particular care pathway, trying to understand barriers and facilitators to implementing or improving practice. And everybody wants this really fast. Implementation research is where we really study the methods and the tools that have been used to translate evidence into practice to really understand what the active ingredients of success are. And that can be incredibly slow. But this bit's really important because if we can understand these active ingredients, we can really narrow down the focus to replicate these methods, generalize these methods across contexts, understand how to sustain that translation of evidence into practice, and also achieve this at scale. So in terms of the precision trial patients, what is the next step? So there are a number of gaps to overcome. We have things in place for tumour profiling, bioinformatics and variant interpretation through the molecular tumour boards and the bioinformatics that have been discussed through the cases that were presented today. And we also then need to understand more about how we can more rapidly have evidence-based therapy matching and selection through evidence assessment, prior therapies and clinical factors. And some of the things that Helen was talking about and Melita around the literature reviews that need to be undertaken to really understand how to inform that decision making is crucial, and it takes a serious amount of time. We also have clinical decision implementation, so access to treatment development and financial toxicity, and health system implementation. So there we're looking at infrastructure and the relationship between different databases that hold crucial information about patients, care coordination, all of these different clinicians that are now becoming more and more involved in cancer patient care, and the expectation management. So the aims of this research were to try and overcome some of those challenges through the co-design of a precision care clinic, its implementation platform, and a suite of outcome measures so that we can really understand to all the different stakeholders what success looks like and how we can measure that. The second aim is to test the implementation, service, clinical and cost effectiveness outcomes of a precision care clinic, and then to develop and pilot test a precision care clinic scale-up model and toolkit. And to date, we don't know exactly what that's going to look like yet. This work has been funded through a Rapid Applied Research Translation MRFF grant. So the precision care clinic, essentially we started to build exactly how it operates through a method that we use in implementation science called process mapping. And so this is around about the 6th version of this map. And I guess the key elements to point out really are in purple. We have the clinic stream, and the light purple you can see we have medical oncology and clinical genetics, and those two streams are inherently related, as David Thomas mentioned earlier on. And then we also have the molecular MDT stream, where most patients go, and some patients, as David Goldstein mentioned, will be seen in the clinic. In addition to that, we're trying to incorporate research, really integrate research into the health system. And so you can see with the red boxes, the dotted boxes, where we have some key research activities underway where we can talk to patients, survey patients, and also clinicians, both within and outside the clinic. And we also observe MDT activities as well. And so in a nutshell, this is what the clinic entails. We have the referral, MDT meetings where principal managers of the patients from outside the clinic are invited to take part in these discussions so that it's a joint decision-making process. There may be this option for clinical consults, and then there's also a summary letter, regardless of the consult taking place, that will go back to the managing clinician. And alongside all of this, we have the research. You've met many of them today, but this is the clinical team, including Kathy Tucker, Frank Lynn, and Bridget Douglas, who aren't here today. And then in terms of the research, apologies for this slide, it's kind of gone a bit wonky, but we're really looking at co-designing the really crucial outcomes of the clinic, mainly to inform what resources will be needed and how cost effective will this be to inform a broader, more sustained translation of this kind of clinic or this kind of service into clinical practice. So we have the clinical intervention, which is precision medicine, and then we have our service intervention, which is the precision care clinic, consists of the MDT, telehealth services, streamlined clinical pathways, and the precision care clinic platform. So here we have the learning health system, which David Goldstein mentioned earlier, a learning implementation system, which I'll discuss in a little while, and then also evidence-based implementation strategies. So really, these are all of our inputs that we're trying to capture at this level. And then we have things like implementation outcomes. So trying to understand from a patient and a clinician perspective the acceptability of the model of care, the extent to which it's being adopted among referring clinicians. Are clinicians referring in? Is it feasible with an existing work and processes, and is it sustainable? So can we use things like a learning health system to capture this really unstructured information that we're collecting about these patients and the implementation process that are occurring, and you structure this information in a way that can help to improve the next iteration. We've got service outcomes, so we're looking at things like uptake of clinical trial referrals and genetic referrals, uptake of germline testing, precision oncology treatment recommendations, multidisciplinary collaboration, clinician training and upskilling, time to clinical trial referrals, and time to genetics referrals as some examples. And then at the patient level, we're looking at we want to improve the patient experience of care, satisfaction, and really Melita demonstrated that, on a very specific case level earlier on, and we're finding ways to measure that in a more systematic way as well as through interviews. Experience of care coordination and improved health-related quality of life. And I guess with all of this, there's a real central focus on equity. So as David mentioned, we are really looking to make sure that we can cover the geographical location of patients and provide the care that they need no matter where they are. This really is just a busy slide around data linkage and really shows the complexity that we're working with to try and collect data from many different databases that can tell us about how the clinic is operating, and I guess trying to really inform through the patient information that's gathered how the decisions for the next patients can be improved upon. So I won't go into too much detail, but luckily we have a data scientist managing all of that side of things. And I guess all of this information that we're collecting, in the centre circle, we're looking at a learning health system, so collecting things like from the MDT reports and the literature reviews that are informing that, to make these recommendations and provide feedback, evaluate that and enable in an artificial intelligence informed way to extract that information and keep in perpetuity, that iteration that will continue to evolve the evidence and the decision making. And then on the outer circle, we're also collecting information about barriers and strategies that we face in implementing the clinic, so that we can also have a database structure this information, so that when we come to think about scaling up, we've got a more evidence and systematic based approach to be able to drive that forward. So progress to date, we received the funding in October 2022. We've gone through ethics and governance. The clinic and MDT was established at Prince of Wales Hospital in July 2023. And we also started process mapping then to design the clinic functions. Data collection was initiated in 2023 in November, and that's where we've collected a lot of information from pilot patients about their experience, but also interviewed them to understand to them what success looks like, so that that helps to design the measures that we use to measure the impact of the clinic. And March 2024, we had the clinic and the website launched. So we hope that we're overcoming a number of these gaps through the molecular multidisciplinary MDT, artificial intelligence, clinical informatics, clinical trials matching and access support is something that we hope to be able to facilitate. And then there's still things to come, like novel access frameworks, industry partnerships, and public access reimbursement. If you would like to participate as a stakeholder, or know somebody who might be interested as a clinician, or somebody who's interested in this area of work, then please scan the code. And this is just a list of acknowledgements of all of the people who've contributed to this work.
Questions?
There's a question online. In some of the cases presented today, would genetic testing done at the start of conventional chemotherapy have led to the spectacular results we saw at a much earlier time for these patients? And is that a practical thing to do?
So I guess that's part of what this whole process is learning about. But David would probably want to answer that. So the evolution from most to CASP in when people are being studied, and what you learned from most that has driven the changes to CASPs, probably what the question is.
This is about earlier testing.
Yes.
Yes. Yeah, I mean, there's multiple ways to get increased cure rates, but one of them isn't just to be applying treatments in settings where patients have very advanced disease. Think about the immunotherapies. You know, the response rates to immunotherapy in the adjuvant setting, say in rectal cancer, David, as you know, is spectacular when you treat a patient with immunotherapies in the neoadjuvant setting with MSI positive rectal cancer. You get complete responses, whereas, you know, you might eke out a few more months of survival. So I think shifting into the earlier setting makes absolute sense. In our study, about 10% of patients had got so sick that they died by the time they got the treatment results in the MOST program, and that's motivated us to go earlier in the cancer journey as well, combination therapies and other things of that kind.
So that's a short answer to that. Just while you're up here, David, if I can take prerogative and jump in, for our multidisciplinary audience, right, the idea of where you see this could go outside of.
Yes, and I'm sorry, you did ask me to speak to that. Look, the fundamental principle here is based around the idea that science is progressing faster and faster. And in the case of oncology, it's become shovel ready to the point where the objective response rate in a phase 1 clinical trial today of a targeted therapy in a patient with that target is now 31%. I'm a sarcoma specialist. The frontline response rate to doxorubicin in a patient with metastatic soft tissue sarcoma is still standard of care at 17 to 23%. So you're better off just going on to a phase 1 trial if you happen to have the drug target. The question is that our system is not designed that way. And one of the things that I think we need to bring out is that research is getting to a tipping point where it actually constitutes something that is a meaningful standard of care, not a nice to have extra for academics to become preoccupied by. But how do we develop our healthcare system, and does it have a role potentially in paying for the costs of treatment? Therefore, the general rule here is that introducing, as you get to a tipping point where research is accelerating and becoming more and more effective, trying to weave that into your clinic's function is, I think, the core part of the model. And that's by definition research-led, evidence-based. So I think there's a role for developing similar models where we can work with industry to provide more trials for our patients today in the interest of our patients as a standard of care. And I think that's not a purely oncological thing.
1 minute and one more question, if that's okay, and then I'll quickly check with the room. Is the clinic physically at Prince of Wales, or is it at UNSW? Are they at the Bridle Lines, and which rural sites?
Process. Prince of Wales is the first example, but can't be the only one. Prince of Wales is about finding out what not to do, and then use the other hospitals that have been designated to do it better, and then show that it's sustainable across a health system. Just one hospital is not going to tell you about a health system.
Before we wrap it up, thank you so much to Medical Oncology and the genetic team
Thank
and
you.
UNSW for the great presentation.